Right. Good evening to everybody. Thank you for joining us. I'm Bert Siong, the Democracy and Scrutiny Officer, and it falls to me to start the meeting tonight on account that the chair is not present. The first item on the agenda is election of chair. So could I have a nomination, please?
Councillor Hannah Andrews.
Seconded? Seconded, okay. Councillor Andrews, you're duly elected chair of this meeting. I'll hand over to you. Thank you.
Thank you, guys, and welcome to our Scrutiny and Health and Social Review Group meeting for Thursday, 16th September. I'll just read out procedural stuff very quickly. So obviously this meeting will be live streamed to the public. A recording of this meeting will be available on the council's website within 24 hours of the meeting. Obviously, attendees are required to wear a face mask on entry to the building and meeting room, which may be removed when seated. Would everyone in the hall please ensure that you have scanned the QR NHS COVID app poster with your mobile phone located at the entrance of the chamber? Would members and officers please remember to switch their microphones on, and when speaking, and speak directly into the microphone and switch their microphones off when finished? And please switch off your mobile phones or place them on silent mode, please. Do we have any apologies for absence?
Chair, we have apologies from Councillor Underwood, the chair, and Councillor Campbell.
Thank you. Minutes for the 4th of August 2021. Have everyone had a chance to take a look at these? Everyone happy with these? Yep. And the 23rd of August, everyone happy with these as well? Excellent. Does any members have any disclosure of interests? No? Okay. Any urgent business?
None, Chair.
Any reference from committees or other bodies?
None, Chair.
I have no chair's updates. So moving on to report, we have a update on COVID-19 in Luton, which is on page 19 to 30, and I believe, let me just find that.
Sally Clark, right?
Sorry, Sally, over to you. Thank you.
Thank you. So in the usual format, I've submitted a paper, but I have slightly more up-to-date information since that was submitted. So as of today, the case rates per 100,000 are 384. There has been a gradual increase since the end of August in our case rates, but they've started to drop again. And that's the same picture as is being seen across the east of England and across England as a whole. We are currently, though, above the east of England rates and above the rates for England averages. Our greatest increases have been in recent weeks in the 0 to 10-year-olds. So particularly starting to see the impact of children going back to school in our cases. But our highest rates continue to be in the 11 to 18-year-olds and the 19 to 22-year-olds. So those teenage years and young adults. We have, as usual, sort of higher rates in some wards than others, and we're looking at doing a bit more of a deep dive on some of the data around that. So looking really closely at some of the cases and some of the numbers in different areas to see if we could perhaps take some additional actions, such as targeted testing or increasing our vaccination targeted work in certain areas. So we're doing some work looking at what more we can do in particular geographical areas to help prevent spread of infection. We are seeing a bit of an increase in numbers of cases that are travel related as well. So we're looking at whether there's anything further we can do in those situations. There is more limits now to the tools that we have to be able to take action. But one of the key things that we can be doing is increasing testing in certain areas or in certain situations, and just working as we continue to do to increase vaccination uptake rates, which is absolutely key at this stage to being able to control the ongoing risk from COVID. School numbers, as I mentioned, are increasing. We have set up a very clear standard procedure for schools to take forward if they have an outbreak. So they get in touch with us and we give them some advice and some measures to put into place. And in some cases, we recommend reintroducing wearing of face coverings or reintroducing of staggered starts and measures such as that to keep infections low. And in some cases, we will have to hold an outbreak management group meeting where we look at the situation and measures in place and look at whether there's anything more that can be done. I have also updated in the last health scrutiny meeting, which I wasn't actually in attendance, but I believe there was some discussion about long COVID. So we have put together a briefing which is attached as an appendix. So I will just talk through that briefly. And then I will open up to questions following that. So the briefing you've got in your papers, it just explains what long COVID is. So it's emerging, the picture around long COVID. And since the beginning of the pandemic, we've seen emerging evidence and testimonies showing numbers of people that have symptoms of COVID long after the initial acute phase of the illness. Studies have shown that it can affect the whole spectrum of people that have had COVID-19. So from those that had very mild acute disease and to those that were really quite ill with it. So the evidence and data around it is still emerging and not fully understood. So there's quite a lot of research that's happening nationally about long COVID and how people are experiencing it and how long for. So in terms of the evidence and data that we have on it, it's relatively limited at the moment, but as I said, lots of research studies underway to understand that better. In terms of prevalence, about 1.5% of the population are experiencing self-reported long COVID, according to one study. We don't have any data on what that will look like for Luton whole, just because of limited surveillance around long COVID and collection of the data at the moment because it's so new. But in terms of recommendations, it would be great if we could understand the picture in Luton better going forward. So we just tried to summarise in this paper some of the anticipated effects on local systems. And as I said, the data is currently limited, but we do have some data from national work that's happened. So we know that there's greater prevalence of long COVID in more deprived areas. So we can ascertain that would be the same for Luton. So thinking about where there's higher deprivation across Luton, that it's likely that there will be a greater problem with long COVID. And this would potentially have an impact on a knock-on impact on mental health, which we also know is linked to deprivation. So the two could exacerbate each other in terms of the effect on the population. There will be as we go forward, knock-on implications for service delivery that we will need to keep a very close eye on and think about referral pathways between primary and community care, rehabilitation services and specialist services. So as we go forward and perhaps get more data and information about the burden of long COVID on the population, we'll be able to develop services that are appropriate for that. There's also a potential impact on employment. So if people are unable to work, suffering from long COVID for long periods of time, that has the potential to have greater impact on inequalities and widen deprivation seen in the population. So there's a graph on, apologies, I haven't got the page numbers in front of me, but there's a graph around population by employment sector and long COVID prevalence. And you can see that the impact is expected to be greater in social and healthcare sectors, which is of course a worry because those are the sectors that we really relying on at the moment to help us through this pandemic and through the impacts and continuing demands on services as we're coming out of the pandemic. So that is a risk and a worry that we need to keep a close watch on. So in the paper, there's just some conclusions at the end, and it is early days with long COVID, so it's difficult to really be able to say this is the impact and burden on the population at the moment, and this is what we're going to do about it, because it is an emerging picture. But in terms of the conclusions, what we can say is that it would be helpful to better understand the prevalence of long COVID in the Luton population. And we'll look at some where there's opportunities to use modelling to achieve this based on national data. As we go, we'll need to develop a greater understanding of the impact and consider long COVID in some of the health inequalities work that we're undertaking at the moment, thinking about the impacts of the pandemic. Will also need to be considered from an NHS and social care perspective in terms of service pathways and capacity and delivery. So will need to be considered as we go forward in a way that obviously we haven't had long COVID as an issue in the population previously. So it's a new consideration that will need to be taken forward as we go forward with services. And I just wanted to also then mention that in the last meeting, again, that I wasn't in, but I believe there was some discussion around modelling and thinking about impacts over winter of COVID. So I just wanted to update on that. We are taking that forward. I haven't got any updates here now on that, but I will bring something back to the next meeting. So we're looking at, there are models that are around, academic models that are trying to look at what the potential impact of COVID is through the winter. They are national models though, so my understanding is there aren't any that extrapolate down by borough level, but what we're doing is looking at whether we could do that ourselves or whether there's some data behind the models that we could use to make estimates for us in Luton. So I've got somebody in my team that's having a look at that, and I'll bring something back to the next meeting. Thank you.
Thank you for your report, Sally. Does any members have any questions? Yep.
Thank you. Very interesting. Is there any correlation between long COVID and obesity?
Not that I have seen, not that I'm aware of, and that we came across in doing this briefing. So I'm not an absolute expert on long COVID, and as I said, it's very new. So there's not a huge amount of known evidence as yet, but as far as I'm aware, there's not a correlation.
Is that okay, Jeff? Yeah. Thank you. Anybody else have any questions? No? Okay, well, thank you for your reports. Oh, sorry.
It says somewhere in the report that some long COVID sufferers have reported kind of improvements since receiving vaccines. How in depth is that knowledge? Is that just purely anecdotal, or is there some kind of hard written down data for that?
There is limited evidence, and
Yeah.
actually the paper doesn't have a reference in there, does it? But
No,
so it won't be through randomized control trials or that really robust evidence base for that. I can look into that a bit more, but I imagine it's through early sort of case-based reporting directly from doctors themselves, rather, because there hasn't been a long enough time to have longitudinal cohort studies or randomized control trials that give us the really robust evidence. So I imagine it's through case reporting, so quite limited evidence at the moment. But I'll look into that bit specifically a bit more because actually it's a really good point that another tool to try and make sure that vaccines are seen in a positive light to help improve our uptake, which continues to be a worry. So I will look into that a bit more. Thank you.
Thank you.
Anybody else have any questions? Thank you for your report, Sally. So the committee is recommended to note the report. Noted. So over to item 9, which is GP access, and I believe that's over to Nikki.
Thank you, Chair. So anyone that doesn't know me, I'm Nikki Pillane. I'm Director of Primary Care for Bedfordshire, Luton, Milton Keynes. So I've sent you some slides, but I'll just pick up the key elements and then take some questions. So following on from Sally, clearly we still have COVID and our GP practices, as other healthcare facilities, are holding all those protective measures, which is social distancing and the use of face coverings. And most importantly, it's using clinical discretion and clinical decision making of those patients that need a face-to-face contact. So if I say the pages in the pack, because I'll use the pages in the pack. That's probably easier. So on page 21 of the 28, it does emphasise that practices are managing what we call the premises constraints, in that if you're giving that social distancing, is that you, in theory, you can only manage half the amount of people. Now, clearly, many of you with using practices yourselves in Luton will know that some practices may have only one entrance and exit, so it actually makes it quite considerably different. So just giving you that context. So probably the smaller practices are more challenged in that basis. So again, just want to put the context. So at the moment, the GP practices and all 26 in Luton are providing care for patients with symptoms of long COVID. So just picking up Sally's point, is there is a referral pathway which is beyond the 3 months. So up until the 12 weeks, the GP practices are funded to provide some additional support for long COVID. And interestingly, and this is just anecdotal from talking to clinicians, there are many people that literally at the 11th week do improve. And that is the reason why there isn't the referral onto the next service, which is a BLMK service, until the 12 weeks. So there is clinical rationale for that. And clearly the GP practices were managing the COVID vaccinations. That will all commence again. I was on a national call today, so that will all commence from next week. And of our GP practices, not all have taken up providing the boosters, but I've got details on that if you want, but let's just home in on the GP access at the moment. I think the other part with GP access, that in Luton in particular, it's about working with children's and families about the outstanding childhood vaccinations and IMS. And it's always useful when I'm near Sally, because as the public health consultant, she will say probably measles is more of a concern to young children than COVID. So in no way would we want to jeopardise putting all our eggs in the basket of doing COVID vaccinations without looking at the basics. So doing those, catching up with those children's outstanding is really important, in the same way as it is a screening. And sometimes GP practices do quite a lot of promoting, for example, the breast screen, although they don't do it themselves, but practices themselves do the cervical smears screening. And the other area is long-term conditions. So anybody who's had long-term conditions, we know, not just Luton-wise, people have refrained from coming forward, but we do need to get those routine checks in particular. So I think the other point, just to make a note, and again, this is about facts rather than myths, is that we have unprecedented demand. So we do know that the GP practices amongst BLMK, and at the moment I get the data at a BLMK level, but the rates of consultations have gone up. So our GP practices are seeing more patients today than they were pre-pandemic. So if I just move on to what is our slide 4, but in the packets, slide 28. I just want to make sure that members are aware of the different types of consultations. So because there's a lot of jargon in there. So at the moment, we've got 23 out of the 26 practices that are currently using video consultation equipment. It is available to all, but we've got 23 out of 26 actively using that. So that means that the clinicians, because remember we've got multidisciplinary teams in general practices, that the clinicians will use a video consultation, and that is available to them. The online consultation, people muddle, but the online consultation is where people who've got access to internet, and it is literally you pull it down and you write in what your issues are, and then it's reliant on the practices making contact back to the patient or the family. So they're the two types. At the moment in Luton, of our 26 practices, we have 19. So we've got 73% that are using that online consultation. Just for clarity, it is up to the GP practices. We've made it available, and we encourage people to use it if it works for them. But again, I can pick that up if people particularly want to dive in on that element. Certainly working with many colleagues in Luton, particularly Health Watch, we have worked through something we've called it the General Practice Access Campaign, and that is really helping people to use the service. So the two that I've just explained are video consultations and the online, helping people to understand that. I just want to make sure that the hyperlink that was in the pack, and I know because I tried it, but I hope the new one went in, because it's a really good animation film that works. And if anyone's tried it and it doesn't work, we'll make sure you've got the right YouTube link. It's a very useful, and I think quite a few people have tried it and thought it was quite helpful, explaining the different roles and the different ways of accessing GP services. I'm not going to in any way detract from that the telephony amongst the 26 practices is quite varied. Some practices excellent, and some practices is really challenging, and it can ring and ring and ring. Now, how I've had it described to me, and I'll see if I can do justice. If you imagine with the telephone system, it's a bit like having lanes in a motorway. So if we've got more of the clinicians in general practice ringing out from the practice, they're using lanes in the motorway. So that is why some patients can get really frustrated where they're dialing in and there's no answer. And it's because so that's an element of the telephony. It's quite complex because that's not the case in all. What I'd like to give this committee some assurance is that we are working with the regional team, and we're at the moment piloting some telephony that completely links in with the GP IT systems, so that if I was to ring my practice, it would automate it and it would come up, it would see my name, and it automates notes that go into the patient's notes. It makes it hugely easier for general practice staff. So that is something my job is to make it as easy for the GP practices to be using, so that telephony system. At this moment, the GP telephone systems are the responsibility of GP practices, and clearly the upgraded telephony systems are expensive, so that's what we're working through. Now, I'm not saying that's going to be the cure to everything, but I think it's just being forward thinking as that work is taking place. I think on the point of telephones being answered, and this is not unique to Luton at all, and it's something that we're looking at a regional level, there are frustrated patients or residents that when they get through have been quite abusive to reception staff. And we have had reports back from GP practices, and that's partly why we've undertaken this GP access campaign, because clearly if we've got staff that are receiving abuse, and you appreciate that the patients and the residents are upset, but we are noting that there is a lot of staff, it's quite a turn of people resigning. So my job is to support the GP practice, the employers, to make sure that staff aren't in any way receive verbal abuse, because they're only trying their best. So anything we can do to help in that, it would really be helpful. And that's why we've used the words about navigating the system and humanising it, because I don't know any member of staff working in general practice that's not there trying to do the best. So that's the main thing there. With regards to, and in the pack, it just says, and it gives you a feel for in the BLMK. So in February, 417,000 appointments. I mean, they're huge, and that number went up. If you do a comparison, 436. So the numbers are huge. To members of the scrutiny meeting is that, and I know some of members here are part of it, but recognising this is an issue, we have something called a primary care access programme, and we've got various work streams that are all working to try and contribute to supporting it. I know in the last meeting I really homed in on the 111 service, because that's all an interface and it all helps to support GP appointments. So just to home in on a couple of areas is that some of the initiatives, the work groups, and if I work on the practices that we know with variation of the 26, is that where practices themselves are struggling, we have a GP Access Improvement Task Group, and that is us being very formative and supportive. And we also have external support from Region that's called a Time for Care programme. And that, again, is really doing that absolute analysis of the issues and trying to support, how the practices deal with it. The other one I just mentioned is about integrated, what we call the urgent care group, and that is all the interface with the 111, remembering the GP out of hours, because we always emphasise that our GP service is a 24-hour service, and we certainly wouldn't want people using inappropriately the A&E departments because primary care's failed them. And that is equally in Luton, we're very privileged because we've got the urgent GP clinic and we've got the urgent treatment centres. So that we're working in a way that's collaborative, so that we're working as the residents of Luton will be able to access the right place at the right time when we're trying to work as a system. And then the other one I just want to mention, Chair, is what we call the GP Community Pharmacy Consultation Service. And that is a service, it's an evidence-based approach. So it's worked from what we call best practice from the national and regional teams. And that's very much working community pharmacists with GP practices, and we're working that through in a phased approach. So, for example, Level are working on that. I will just, I've probably mentioned, yes, just some of the other areas is working with Healthwatch, equally working with yourself. Scrutiny meeting is about giving us some of the detailed issues. So, for example, we are very aware of people with long-term conditions, for example, who have an outstanding, say, asthma assessment or a diabetes assessment, of working with the practices to try and get appointments. So again, able to pick up, and that very much is the 26 practices in Luton using the CCG primary care team to support where there's an issue. For example, Dr. Bakai, who you've met before, Shirag Bakai, he is our strategic lead for long-term conditions, and he has done quite a bit of work specifically aimed at residents, patients with long-term conditions. For example, there's some additional capacity that's been put in for people with diabetes for their checks. So if I pause there and take some questions.
Any questions yet? Anna?
Nikki, at the beginning of the pandemic, my doctors, they left the online booking of telephone appointments. Now everybody's got to go through the telephone system. So you've got people who want urgent care, or people like myself. Yes, if I talk to a doctor over the telephone, I would be quite happy. We're all trying to get onto the same system. And I just think, using the online, this video conversation, how many surgeries are they actually using that?
So the surgeries that are and it tends to be the smaller practices, which is, in fairness, about capacity. If they're on, and this again, and I don't think Nina was on tonight, but the feedback we've had from the clinicians often doing the online consultations and the telephone is hard work. It is easier to bring patients in. Face-to-face work is, and again, I'm just relaying back what we've heard from clinicians. However, they're having to take a balanced approach about what is in the best interest of the patient. So if they genuinely believe that they can undertake the consultation remotely, which is either on the telephone or the video consultation, they will. But just making sure I've answered your question, is it that you're saying that some patients can't access the service?
Well, the thing is, you dial the number and you get told you're 25 in line. So there's the frustration before you even start. And anything that you could do online rather than using that telephone, I think you wouldn't be getting the abuse that the poor receptionists are getting, because you can imagine if you stay on the line for that length of time, your frustration is sort of building, and it's just for a simple, you know, something that you've got a concern about. It's not urgent.
And that again is where we are facilitating. So at the moment, we know that we've got 7 practices not using the online consultations. So we would like to encourage the practices, if somebody's wanting to make an appointment for a long-term condition where they're using that facility. Now, clearly, I wouldn't in any way ever suggest that I would know how the practices want to run their businesses, but that's where we're working with the practice managers, particularly, and this is where it's really helpful to know if there's specific issues in particular practices. We know, and that's probably working closer with the Health Watch, we know the practices where patients have got more frustrations, and that's where we will facilitate and say, what's happening at the moment isn't working for your patients. And that's where it's in that supportive role that it's about getting change. So I absolutely hear exactly what you're raising.
Councillor Pett.
Well, mine's kind of a similar thing to Anna's. The practice that I belong to, they won't do any face-to-face. Now, it's extremely frustrating, and as Anna said, the amount of time you spend on the telephone. We spent nearly 3/4 of an hour the other day trying to get an appointment for my wife. And people, certainly in my constituency, and people that I know, are losing faith in GP practices. And they now say that doctors don't treat it as a vocation anymore. It's a job for them. And they're only worried about generating points. But if you want to see a specialist, my wife had to fight the doctor to get an appointment for an X-ray. And the X-ray, she went about 3 weeks ago she didn't go, but she had an appointment over the phone. The opening statement, my wife has got a problem with her leg. And the doctor was completely unsympathetic and said, as soon as she was on the phone, he'd obviously looked at her age, and he said, it's arthritis. He'd not asked her a question. And she was on the phone for about 20 minutes arguing with him about getting some sort of proper consultation, somebody to look at it. But it was just unsympathetic. I mean, it was pathetic, absolutely pathetic.
So I can take that specific case, but just to give you, so I do have some approximate numbers. So it's about 2 in 10 of the consultations are face-to-face. So I wouldn't want people to think there were none, because we would have an issue, because there will be, you can't say everyone can be addressed without face-to-face. So, and we've worked with the local medical committee. So we do know there are face-to-face, there are some face-to-face, but without identifying as specific, but clearly we can pick that through. But equally, and we're very aware, if anyone's got hearing impediment or actually has got language issues, the clinical decision has to take those social issues into advice as well as what the clinical issues. So I wouldn't want, of all 26 practices, we know there are face-to-face appointments taking place. Yeah.
We're doing jabs for flu. We're talking to people about minor problems, ailments, face-to-face, and yet the doctors won't see patients. And he also mentioned his brother has got a practice in Kent. And most of the practices in Kent are actually doing face-to-face appointments now.
So the good news there is about clinical pharmacists, because that's my role as well. And I have to say, through the pandemic, the community pharmacy, that profession have absolutely come to the fore, because in our BLMK system, particularly in central Bedfordshire, the community pharmacists were a really big group of providers of the COVID vaccination. So we now in Luton, with our 26 practices, I should remember the number. I'm looking at Sally here. I think we have about 9 community pharmacists that are doing the COVID vaccine. I will get the numbers. In the whole BLMK, I think we have 27.
Yeah, I was going to say 10. I think it's 10 in Luton. So a good number.
A good number. And that is exactly, it is a little bit disappointing for me when one professional group talks to another, because I can honestly say of the numbers, and if I look at my team, the GP practices are busy. If I liaise and speak in this very room, Sally and I met with the 5 what we call primary care network clinical directors. So we do know the practices. So sometimes there is perception and reality, but at the end of the day, our job is to make sure that we're providing a service to the residents and the patients. So I will take those, absolutely back.
One other thing that might be of interest as well. But I believe that there are patients dying in Keach that shouldn't have died because of lack of care. That was his statement to me.
Again, helpful if you can give me those contact details, because I can certainly follow that through. Because I need to work on, on a primary fact, in the sense if he wants to follow it through. I just equally think it's quite a powerful thing where people say quite serious issues of that. Anybody can make contact with the CCG, with me, and we will raise those. So I wouldn't want to think that that particular practitioner feels that he can't raise the issue. If there is an issue, he professionally believes there is one. Yeah.
Can I just say that you don't have to go and see your doctor either? Do you know, I care for my brother who's had a stroke, and we booked an appointment with the practice nurse. And if there's an issue, the practice nurse will then pass it on to the GP. I also email, can I have an appointment on Thursday morning? And then you'll get a text message back to say, yep, 10 o'clock Thursday morning. And for me, that works great. You don't have to be 15 minutes, well, half an hour, whatever, on the phone. Some practices do offer that, which is brilliant. Yeah.
Again, that point is, and I think that work really very much started in Luton, which we're talking about the team. So we really try and work. It's not just about having the GP, because you're quite right, clinical pharmacists, paramedics, some what we call physiotherapists, first point physiotherapists, practice nurses. It is how the team works. And that is the model. That is the way of resilient general practice. So thank you ever so much for a bit of good feedback.
My GP, I don't want to say which one it is seeing people. When I went there was 4 people in the practice, but they asked you to wait outside in your car until the time of your appointment, and then you go in. So he is doing telephone consultations, but is doing face-to-face. And when I went there was 4 people, because that was the space in the very small practice that they could take. Yeah.
Just to kind of, based on that and how different personal experiences can be different in terms of GPs. And literally yesterday, because last week my fiance, unfortunately, she went to the Ollie Murs concert in Bedford and didn't see it because she slipped on the grass and spent it in the St John's ambulance tent. She's been struggling to walk ever since. She went to A&E eventually, because getting her to go on A&E is a job in itself. And she got, in essence, palmed off. She tried to get through to the GP yesterday. In the morning, we couldn't get an appointment. We didn't get one in time. In the afternoon, we managed it. And unfortunately, I had to go to work. But in that space between then, she had a telephone appointment. She got an in-person appointment with her GP, spent 15 minutes with her GP, which ironically was her first appointment with a GP since she moved in with me. So it was the first one in Luton. And ironically, that GP was very unhappy with the treatment she'd got from the doctor in A&E. So will be personal experience because she's now been sent. Well, our GP is now sent for a emergency X-ray to get a knee X-ray, which the A&E wouldn't do.
Yeah, and I think that this, again, it's helpful because what we're really saying is about variation. And again, my job is not to interfere with the clinical decision making, but clearly it's very evident if people are not having a acceptable experience. So yeah, happily take that back, and thank you very much for those other comments.
And can I add, with my particular doctors, when you actually get appointment, they are fantastic. It's only, as I say, that first point that if you could take pressure off the telephone system, you wouldn't have the, you know, nobody would be frustrated, because once you get it, as I say, my surgery is good. They do face-to-face. They'll even, like with me, they did a telephone call and he said, then, do you mind coming in? But it's just that first point.
Thank you very much, Nikki, for your detailed report. As always, that's been noted. Members, moving on to agenda item 10, BLMK CCG policy alignment, public. I think we've got Sarah Frisbee taking this. Is she online?
Joining us online.
Thank you.
Thank you very much. Can everyone hear me? So I'll keep going. I guess someone will stop me if you can't hear. I've got some of my colleagues here.
Sorry, we can hear you, Sarah. Carry on.
Fabulous, thank you. So I've got some of my colleagues here with me tonight, and I'll let them introduce themselves as we go along. Suda's going to kick off for us this afternoon. So Suda, if you want to take it away.
Hello, good evening, everybody. I'm Sudha Maharaju, one of the GEPs in Luton. This is about fertility services, bringing equality across the patch, BMLK. We used to have 3 different policies doing different things, but considerable common things were going across 3 policies. But being one policy since 2020, we wanted to bring a common policy, which is to consider equality among all the population of Bedford, Milton Keynes and Luton. Prior to the COVID, we had meetings, but it was deferred because of the COVID restrictions. Since the COVID came under control with the vaccination program being successful, and we are mindful of the circumstances of fertility services resuming again, we decided we will discuss the policy and consider consulting again to bring a single policy across Bedford, Milton Keynes and Luton in one CCG. This is a presentation to consider equal access of our services. That is why we are bringing this to the meeting.
Thank you, Sudha. So just to be clear to the committee, this is an overarching policy alignment consultation. So we have three policies that when we came together to form one CCG were substantially different. So fertility services is a big part of it, but we've also got 2 other elements, which is gluten-free food on prescription, as well as pharmacy first service. And Fiona Garnet will be able to talk you through a little bit more about those 2 services. Fiona, if you'd like to come in.
Thank you, Sarah. So my name is Fiona Garnet. I am the Associate Director and the Head of Medicines Management for Bedfordshire, Luton and Milton Keynes CCG, and I work very closely with Nikki Pillane and the primary care team. As Sarah said, I'm going to talk you through the gluten-free service and the minor ailment scheme. So the current situation across BLMK is that the former Bedfordshire CCG and the former Milton Keynes CCG have both been to consultation and withdrawn gluten-free foods on prescription. However, the population in Luton, and I think just to put it into perspective, there are in the region of 100 people currently in Luton getting gluten-free foods on prescription. So this would impact 100 people, around about 100 people. And they can currently get bread, flour mixes, and those types of product on prescription. And the intention is to go out for consultation to come to a single situation across the system. The preferred recommended situation being to withdraw prescribing to all residents in BLMK CCG. However, ensuring that there is always a scheme for our vulnerable patients, so those on, for example, low income, universal credit, pension credit, so that our most disadvantaged patients would not be impacted by that decision. And we would move to a community pharmacy-led model for the provision of the gluten-free foods for those patients to reduce the impact on our clinicians in primary care. So that is the situation with gluten-free. The minor illness scheme is a scheme that has been available only in Milton Keynes, and it allows people on low income to obtain common everyday self-care items free of charge without a prescription. But these are all items that are freely available to purchase from supermarkets and pharmacies. They're not prescription only medicines. They are true self-care medicines, and they are all for self-limiting minor conditions, not long-term conditions. And this scheme has currently only been available in the former Milton Keynes CCG, and again, the intention would be to essentially withdraw the service. The rationale for this one is really due to the community pharmacy contract changing, in that we have, as Nikki very kindly mentioned earlier, we have a new service which is available nationally through community pharmacies, which is the Community Pharmacy Consultation Service, and it enables people to clinicians both in urgent care, NHS 111 and GP practices to refer people to community pharmacies for a self-care consultation. And we think having the two running side by side would potentially be quite confusing for patients. And we therefore think the sensible thing would be to remove the service in Milton Keynes, but we would have the community pharmacy consultation service available to the entire population and all practices in BLMK. So I won't go any further, but I'm very happy to take any questions. Unless Sarah would like questions, wait until the end.
If okay, we'll move on just to talk about the final element of the policy, which is of the policy alignment consultation, which is Duncan. Duncan, I don't see you. Can you hear me okay?
Thank you, Sarah, and good evening, everyone. So my name's Duncan McConville. I'm one of the senior commissioning managers at the CCG, and I'm supporting the work around the policy alignment in relation to fertility. So I'll just give you a brief background to that policy area. So currently there are 3 existing policies relating to fertility across all 3 of the previous CCG areas. So Luton, Bedfordshire and Milton Keynes CCGs. And the access criteria within those existing policies varies, and notably the number of cycles offered within those policies varies. Within Bedfordshire and Milton Keynes, there is 1 cycle offered, and within Luton, there are 3 cycles offered. So that variation within the existing policies is due to historic commissioning decisions that were made by those 3 individual CCGs. And that has led us, as my colleagues have been describing, to the point now that we are a single CCG, that we are looking to align those 3 policies into a single policy which covers the whole of BLMK. And the priorities essentially driving that policy alignment are to address the inequalities that we have inherently within the access criteria defined in those existing policies, and also the number of cycles defined in each of the existing policies. So we are looking to align the number of cycles, align the access criteria, and that does include widening the access criteria to include specific patient cohort groups such as same-sex female couples, single females, and trans men with uterus. And that we are hoping will address the inequalities that we've addressed within the BLMK boundary, but also we are looking to address the inequalities across the wider area, across the east of England and the East Midlands, caused in part by the existing policy that we have of Luton offering 3 cycles, which is in effect contributing to that postcode lottery. Currently, there's only one other CCG within that area that offers more than 1 cycle. So equally, I'm more than happy to take further questions, but I'll pause there following that introduction.
Great, thanks, Duncan. And I'll just finish off just giving the committee a very quick update on where we are with the consultation process, if that's okay. So we are currently in a period of pre-consultation engagement, and we're taking that time to review some of the documents that we've written. We just want to make sure that the Case for Change document, the EQAAs, the access criteria appendix is right, as well as the language that we are using is right. And that's just to make sure that the documentation that we go out with when we move to formal consultation is as robust and correct as it can possibly be. We've done our best to make a start to it, but we were conscious that we weren't altogether the experts on it, and we've taken that opportunity during pre-consultation engagement to talk to some of those experts. So we've worked with an EQAA expert, particularly around the trans men with uterus, just to make sure the language is right and that the EQAA is tough. We've also met with Fertility Network UK, who have been really good with giving us some critical feedback around the document and how we've worded things, and if we've been explicit enough around cycles and that kind of language that's around fertility. That was a really useful conversation, and they've offered their help as we continue through our consultation process. We've met with all 4 health watches for the Bedfordshire, Luton and Milton Keynes area, and again they've provided some comprehensive feedback on all areas of the consultation, including the Case for Change and the draft questionnaire that we've got ready for formal consultation. We have made initial efforts to get in touch with Celiac UK, which up till now has been a little bit unsuccessful, but one of our health watches has got a little bit of an in. So we're going to take full advantage of that and see if we can get a conversation in with Celiac UK whilst we're in the pre-consultation engagement phase. So in terms of next steps, we will collate all the feedback that we've received. We'll make any changes to further strengthen our documents where possible. We will take the pre-consultation engagement report back to our governing body, which will be on the 28th of September, and we'll look to move into formal consultation from the 12th of October, which will run through right till the 21st of December. That ceases the formal consultation just before we hit the festive period, during which time we're unlikely to receive a lot of responses anyway, and gives us ample opportunity at the other end of the formal consultation process to do all the analysis necessary to be able to take it back to our governing body, I think at the start of February that is now, where they'll be able to make a formal decision based on the feedback that we've received. I think I'll leave it there, Chair, and open the floor to questions to any of the questions for any of our presenters, please.
Thank you, Sarah. Anna?
On the fertility, on page 38, about that there's dropping numbers of people actually using the service before, well, you've only given us 18, 19. Do you think that after the pandemic that will continue? or will we see more people presenting because of the numbers were low during COVID? What I'm saying is, you're saying it was dropping previous to COVID. Do you think it will still continue to drop?
Duncan, do you want to do that one?
Sure, thank you. So it is correct. I'm just making sure that I'm understanding the question correctly. So throughout, or rather when the pandemic started, that led to temporary closure of fertility services, and obviously also had an impact on primary and secondary care services temporarily, particularly around the first wave of the pandemic, which has ultimately led to a reduction in the number of patients who have been able to receive fertility treatment through that period. So we have definitely seen a distinct drop over the period of the pandemic, and we do fully expect, and we are seeing the signs of activity to returning to pre-pandemic levels. Does that answer your question?
My question is, in this document, you say that these numbers show a year-on-year decline on the use of the service, even prior to the COVID emergency. What I'm asking, do you think that trend will continue? Probably that's what my question should have been in the first place.
Apologies, I
Sorry
misunderstood
about
your question. That's okay. So we have based all of our assumptions on maintaining an activity level of pre-COVID levels. So we haven't assumed a continued reduction. We have assumed a plateau of activity.
Answers my question. Thank you.
Thank you.
Any other members have any questions? No. Thank you very much for your report, Sarah. Thank you. What am I doing?
Thank you very much.
So that's the end of the reports. I think officers can now, they can leave if they wish to. It's just a draft work programme.
Thank you.
Chair. Thank you, Sarah. Chair, the last item on the work programme is usually the one that I say that members are asked whether they're happy with what they've read in the work programme so far, and also if you've consulted the forward plans, which was attached to the document, and there was a latest one forwarded to you by email only this morning. If you've seen anything there that you think the committee should be looking at, then obviously if you speak up now, then I can make a note of it.
So I'm just looking at the 18th. It seems like quite a jam-packed agenda, doesn't it, members? I'm looking at the 18th. I think that's our next one, is the 18th of October. Oh, 20th. Oh, why am I doing?
It is the work programme for this committee.
So that was my
You've
mistake.
also got the forward plans affecting Appendix B, and you've got the Health and Wellbeing Board for your information on the as Appendix C. So that you're aware what work is going on there, and if any members was interested in actually attending those meetings.
Nope, that seems fine to be honest. Sorry. Any members have no for the 20th? No. No, seems all okay, Pat. Thank you. Concludes today's meeting. Thank you, members. Thank you for your attendance.